get online. Okay, welcome to the Lurie Children's Community Provider Symposium. So grateful that you're here today. My name is Chad Worley. I am the physician liaison for Lurie Children's. I cover the city north and then the north and northwest suburban region. And I am joined by Julie Kalkbrenner. Julie is the new manager for physician services. So congratulations on that, Julie. And as most of you know, Julie has been your liaison over the years in the west and northwest suburban region. So we are glad that she is joining us today. And thank you, most importantly, for making the time to join us today. This is for you, our providers, our practice managers and referral coordinator partners in the community. And we're just glad you're here. This symposium is all about you and sharing practical insights and updates that help you take even better care of your patients and families in the community, as well as help keeping you up to date on the latest from Lurie Children's. So we have a jam-packed and exciting agenda for you today. So we have Anna Scaccia. She is going to talk about our new Schaumburg Outpatient Center. I know everyone's excited about that one. Dr. David Bieber from our Lurie Children's Epilepsy Center will be talking about epilepsy and surgery clinic innovations. He's got a lot to say and provide for you today. And then, and finally, I should say, Dr. Ravi Jhaveri, our division head for pediatric infectious disease. We'll talk a little bit about the cold, flu, and RSV epidemiology, but we know by high demand, you want to hear about us addressing some vaccine hesitancy. So he will have some practical tips and perspective that's incredibly relevant to all of us, really. And so he will help that. And I would suggest everybody, if you have questions for any of our presenters, please type them in. And after each presentation, I will read them and moderate them throughout the talks. If you are seeing this as a recording, thank you for joining us. And I'm going to ask you to hit like and share and subscribe to the Lurie Children's Physician Services YouTube channel. Thank you again for joining us. So before we turn things over to Anna, I have a few quick announcements to make, so please hang tight, and thank you again for your central work and joining us today. So Lurie Children's, once again, has been ranked #1 in Illinois by U.S. News and World Report for Best Children's Hospital. Nationally, Lurie Children's had 3 specialties in the top 10: neurosciences, nephrology, and urology, and 11 specialties altogether were ranked by U.S. News and World Report. So that's a big honor for us. And because of you, our community providers, you make that possible as well. And you also help make possible that Newsweek has ranked Lurie Children's 5th in 2026 World's Best Specialized Hospitals for Pediatrics. So that is a huge honor for us as well. And again, it goes to all the hard work that our providers here at Lurie Children's and our community providers do to help take care of all of our families and children in the community. So a lot of you have seen this before. I hope all of you by now have received your referral toolkit. Between Julie and I, we have delivered all those to you. But if you have not received one, please let us know, and we will be sure to give you your paper copy of the referral guide. Now, you see on the bottom left-hand corner is a QR code. Now, for many of the practices that I serve, I have talked to many of you about taking that QR code, scanning it, and bookmarking it into your browser, whether it's your phone, your laptop, your whatever device you use that you're working with to send referrals to Lurie Children's. This is an easy way for you to get to our provider schedules and the outpatient center schedules. To access that paper referral guide, there is phone numbers and fax numbers you can get to with this page. All of our services at each location, patient referral forms, and laboratory recs. This really is a quick and easy resource for you. Highly recommend you doing it. If you'd like for more information about that, please talk to Julie and I, and we'll be happy to walk you through it. So each year, in around January, we like to send out our Look Who's New piece, and that is an announcement for our new physicians, leaders, and surgeons that have joined Lurie Children's within the past year. So please be on the lookout for that. It's very exciting for us to introduce you to our new providers. And as you all know, we like to introduce our new providers to you. So if there is any providers you'd like to meet, whether it's in person or virtually, please contact Julie and I, and we would love for you to meet any one of our providers in person or virtually. Coming up November 9th is the start of our Pediatric Pearl series. We have a lot on this one, and I hope you can join us. We have everything from ortho to pediatric obesity to leukemia. We have so many great topics on this one, and I really hope you can join us. Please look for the link that I'll be sending to this to all of you, and it'll also be in the comment section for the recording that you can link to and register. And lastly, before I turn this over to Anna, we have our pediatric coding seminar. Julie has set it for Friday, April 24th in Oak Brook. Once again, Dr. Linda Parsi will be presenting. She's from Parsi Pediatrics. For those of you who attended this seminar in the past, you know how exciting and dynamic of a presenter she is. So it should be very knowledgeable and helpful for all of your coding needs and your practices. But without any further ado, Anna, will you take it over here and have me stop talking and let you do a little bit of that for me and talk about our beautiful new Schaumburg Outpatient Center? I can give you the screen if you like to share.
I just have brief, I can go over some of the services. So thank you, everybody. We're excited, as you may know, or if you're just learning about Schaumburg, we've opened our Schaumburg Outpatient Center October 1st. For all of our clinics, specialty clinics, and other ancillary services. Within in the site as well, there is an infusion center that has been open since August that is actively still looking for patients to be referred to them for their infusions. We have been receiving so far since we've been open in October, nothing but positive feedback from our patients and their families related to Schaumburg, related to the space itself, the accessibility in the northwest suburbs, and then the different amount of providers that we have at the site. So within our, I'll just share, maybe I will share our one screen that I have.
Okay, let me turn that over to you.
Thank you.
Go ahead.
So within the specialty services, we have 17 different specialty services for patients to be referred to for clinics. In addition, for the ancillary services, we have a stress cardiopulmonary type testing, we have EEG, lab, ultrasound, X-ray, and then we have a variety of therapies, including audiology, orthotics, OTPT, and speech. As I stated before, we also have our first outpatient ambulatory infusion center that has its own pharmacy and blood bank to be able to serve a specific patient population. The other thing that we are very purposeful in Schaumburg was creating other clinical services that would help not only the specialty area, but AIC and some of the ancillary services. So we've hired a psychologist, social workers, child life specialist, activity coordinator, and interpreters to be able to help the building complete. So you get some additional type of support services for your patients. In addition, in the next month, we'll be opening up an optical shop. So I wanted to just briefly talk about the services that, in addition to the services that we're providing, our kind of intention related to clinic appointments and the volume of patients that we're seeing. So we've started off initially hoping to see fill up at least 80% to acclimate the staff, our processes. And so we're seeing a positive return that we are about 80%. We're seeing around 200 patients a day, which is really good. Our goal in the next now couple months is to increase that up to closest as 100% capacity as possible. So we'll be adding additional providers and then extra days of session that the current providers that are currently serving in the next couple months. So you'll see the availability of appointments increase as we add on these providers and meeting slots. I think that's all I have. I'd be happy to answer any other questions that anyone has related to the different type of clinics or specialties that we have to be able to refer.
Yeah, so I have a few questions here for you, if you don't mind. So, Anna, could you share a little bit about what into planning and designing the infusion center? What were some of the priorities from a patient and family experience perspective?
Sure. So really nice thing about the infusion center in particular is the inclusion of the patients and their families when we built that area. So it was quite a couple year period in which we went back to the infusion center patients and said, what are the things that you're looking for when looking at an outpatient facility? One of the first things they talked about was having their own kind of private entrance, so that they felt like there were increased like safety for them coming in because of their having an infusion, and just that specialty kind of availability for their patients. So we had that. The other thing that the patients were very concerned about was how their families were going to be comfortable in that area and take care of them as well. So we made a specialized waiting room inside the AIC just for their family, so that they felt comfortable while they were waiting for the patient to be infused. One of the other things we looked for with patients is their ability to be comfortable while getting their infusions. So we had them test different type of chairs and lounge chairs and different type of kind of things inside of the room that they would be able to feel comfortable with when they were in infusion. So it was really nice when we opened up to have them be able to be a part of that planning.
That's great. Will there be MRI?
No MRI.
No MRI. Okay. And then lastly, before we turn this over to Dr. Bieber, is there any additional pediatric specialties or services coming soon to the Schaumburg Center that you can share with us today? Now, I know ENT and ophthalmology are new to this region.
Yes.
That we haven't had. We didn't have at Arlington Heights. But anything else new like that you can share, or will that be to be determined?
One of the other things, though, that we did add, other than ENT, in addition to just general ENT, we will be a little bit more specialized in the coming months related to those type of patients. We added as well epilepsy, that was new to that region as well, with neurology. And we also added our POTS in addition to all the cardiology that we've seen. So those are some of the new programming.
That's excellent. Anna, thank you so much for joining us today. And if we have any questions, we'll send them over to you. But now I'd like to turn this over to Dr. David Bieber. And Dr. Bieber, go ahead, take it over.
Thank you. I'll try and share my slides here, and we'll see if it actually shows up the way that I would like.
There we go. We can see it perfectly.
All right, that should be the title screen. All right. Well, thank you for giving me this chance to talk about the Epilepsy Center. Let's see here. So I'll try and be brief. There's a million different things that we do within the Epilepsy Center. I do like to just point out that we are just a small chunk within the neurology world where we just see patients with epilepsy. The physicians actually mainly see referrals from neurology in the Epilepsy Center. So we see kids who don't respond to first-line treatment. So you may not actually send referrals directly to epilepsy, but there are a few things where we definitely interact directly with our community members. So I'll get into that in a little bit. But just to highlight some of our key things that we do, we see a lot of genetic epilepsies. We have a Spanish clinic for some of our patients with refractory epilepsy, meaning not responding to initial treatment. It's like all of this is multidisciplinary with physicians, nurse practitioners, nurses. We have keto dietitians that do keto diet for children who don't respond to initial medications. There's a lot of neuropsychiatric comorbidities with epilepsy, so we have our own neuropsychologists. We have a partnership with psychiatry. We have our own genetics counselors. There's all sorts of things that can be done within the epilepsy center. Most of these, though, are going to be the children because a lot of kids who get referred to neurology for epilepsy, like new onset, are going to go into general neurology, not specifically the epilepsy center. But just to be aware, some of these are the things that we do. I like to highlight we do epilepsy surgery here. It's a personal interest of mine. I'm not a surgeon, but I do work with patients, the subgroup of epilepsy patients who would benefit from epilepsy surgery. So as part of those that get referred here and then may not respond to initial medications and may benefit from epilepsy surgery. I work closely with the neurosurgeons, radiology, like all of our teams work together for these patients. And just to highlight, we do work here in Chicago and also we do some global health work. This is specifically in Uganda, but we're going to do some partnerships with Poland, Ukraine, Egypt, all sorts of places. But the kind of more, I think, meat of the discussion that most people would be interested is our EEG, because the physicians in the epilepsy center are the ones that read the EEGs. So whether it be the 1-hour EEGs that are done here or at satellites, the 24, 48-hour outpatient EEGs, inpatient EEGs, that's all read by the epilepsy center. And the majority of our capability for like outpatient is downtown. We have the most rooms here, the most capacity to do EEGs, and most that get ordered will end up scheduling and setting up here for that appointment. But we are expanding this. We are trying to do a better job of have satellite options. So Grays Lake, the biggest satellite now for us is Schaumburg. It now has 5 days a week EEG availability. Grays Lake, Westchester, New Lenox all have like 1 to 2 days of like 1 or 2 days a week where we can get EEGs. It's just dependent on room and tech availability, but we are trying to expand that. And so obviously EEGs can be ordered on their own. If anybody has a need for an EEG, this can just be ordered. But I assume most of what, and this can all be scheduled through Kids Doc, and families can go through my chart. And we do have a phone number to a clinical neurophysiology lab. The biggest front is probably Kids Doc for most of our patients that we get referrals for EEGs. But for the neurology referrals for new seizures, to help with capacity for this, because it was a major part of the backlog of neurology referrals a couple of years ago. I was part of a group that expanded our epilepsy center availability to take part in the new onset referrals. So patients who are referred to neurology for question seizure or like definite seizure diagnosis, but needs follow-up with neurology or to establish with neurology. And there was a big backlog. So we opened up this program in the epilepsy center that is this, we called it the new onset seizure clinic. Actually, we call it the same day because part of what we piloted with this was it was an APP or nurse practitioner run clinic. And the goal was to get an EEG in the morning and an appointment in the afternoon so that families would get the EEG because it's a part of the workup usually to counsel families on epilepsies and seizures and risk for seizures and what other workup might be needed. And there was for a while, this big gap between when kids would get their EEG and when they would get their neurology appointment. And there was this nebulous who's like families would get anxious about getting the EEG results. And I know there's a lot of history with orders being pushed back on referring providers who weren't neurologists for the EEG. I'll kind of mention that in a little bit, but this whole idea was to get an EEG, the appropriate test with the appropriate appointment, and to expand our capability for epilepsy or seizure referral. We do now have 5 days a week availability, 15 patient slots per week at the downtown location. And we are now expanding to 4 days a week or 12 patient slots per week in Schaumburg. And this right now looks kind of set up like this, where there's an EEG in the morning and they'll see the nurse practitioner in the afternoon. I am trying to personally push, because this is my own, I guess, personal opinion, that I think the important part is on a neurology referral that they get the neurology appointment and EEG together so that they can get the test that's appropriate with the appropriate person telling them the result of the test immediately. But we're still working on that. The other big thing with this is, I don't actually have a slide for this, but something that I am also working on is, especially children that are referred, like just a neurology referral, who get into our triage, and it is recommended to get an EEG before they are seen in neurology for this question seizure of epilepsy, because it will make the appointment more useful as far as counseling and planning. To have that, if we determine that it's needed or they don't have it and we recommend it, that the EEG order is slowly trying to be transitioned to the neurology provider who's going to see them to order it, so that if you send a neurology referral, it will just, if it's determined that they should probably get an EEG, we will just take it over, and the neurologist who's going to see them, or neurology provider who's going to see them, will get that order and they'll sign it, and the results will go to them, because there has been a lot of this, and maybe some people haven't experienced it, but I've seen it, where these nebulous situations where there's pushback to get the order from the referring provider, but they don't have the results and don't know when this is going to be done. And so I'm slowly trying to push it all towards EEG appointment, same day, with the kind of like what cardiology does with EKGs and appointments, so that we can have it all under our umbrella. But it takes a little while to shift some of these things. So those are the big things that I felt like talking about today. I don't know if there are any questions about that.
Yeah. Got a couple questions in here. I know you have to jump and see a patient in a minute here, so I'll try to be quick. So with EEG in mind, the biggest buzzword in my world, in mine and Julie world, is wait times and access. So
Yep.
with this new EEG ordering, are we seeing a decrease in wait times and available access?
I have been told yes. I will
Great.
admit I don't know the number on that specifically. Sorry.
That's okay. That's okay. It's a question that was brought up, so I got to ask. And then lastly, one last question for you is, Dr. Beaver, for community providers who may be seeing a child for a first-time seizure, what are some of the key signs that indicate a referral to our new onset seizure clinic is warranted?
I mean, that is a fair question. The thing that pops in my head is, I think the new onset is an appropriate referral for anybody with question seizure, even like a first-time seizure, because um, the question is always going to be, are they going to have another seizure or not? Like, if they have one, then the question almost always is the counseling of, do they need to start meds? What's the risk for them to have another one? And a lot of
Mm-hmm.
that has to do with EEG and testing to give you guidance. And so I would
Okay.
usually say anybody who's had a seizure, the new onset is a good, or even just question seizure, the new onset clinic is and we have pretty early availability with that in the matter of weeks, as
Mm-hmm.
far as being able to, like, I think we're at 15 days or 16 days right now to get a EEG and appointment with a nurse practitioner to go through this and talk to them about that.
Excellent. Excellent. All right. Well, thank you so much for joining us today.
Thank you very
And I know
much.
many of our community providers look forward to meeting you in the future.
Thank you.
Thank you. Have a great day.
Okay.
And now I'd like to turn it over to Dr. Ravi Jhaveri. Dr. Jhaveri, thank you for joining us today. I'll go ahead and just let you get right into it. You go ahead and share your screen,
Okay.
and we'll have questions for you at the end.
Okay, that sounds good. I do have a couple of slides in addition to some other resources, so I'm gonna take over. I think we're first going to start with which one here? We're first going to talk a little bit about flu. Okay, so you should see my moonshot photo here.
Yep.
Yeah, okay. All right, so first we're going to talk a little bit about flu, then we're going to touch base about COVID vaccines and recommendations, and then we're going to finish up with a couple of tips that I can try to offer for talking with vaccine hesitant parents. So I've been asked periodically to talk about what I think is going to happen for this coming flu season. So this is my attempt to read the tea leaves. All right. So first, often what we try to do is see if there are clues from the most recent season that just sort of concluded a few months ago in the Southern Hemisphere. It often gives us a preview. It may not be the most accurate preview, but at least it's something about what kind of flu strains are circulating and whether we think that the current vaccine will perform well in our upcoming season. And so the season in the Southern Hemisphere was, I think, not the worst season. It was maybe a little lower than an average season. And they did have a distribution of many of the strains, mostly H1N1, about 60% or just shy of 60%, about a quarter that were tested for H3N2. These are all flu A's. And then the unknown flu A ones just means that they were never tested. And probably are a proportion 2/3, 1/3 of the other H1N1 and H3. Okay, and then as there usually is, there's a little bit of B activity that happens, and that typically happens later towards the second half of the season. Okay. So when we look at these numbers, and this is primarily Southern Hemisphere, meaning the South American continent, there's not as much, there's only a little bit of data from South Africa, but not very much you can see. The vaccine effectiveness was actually fairly reasonable when we think about flu, anywhere, depending on which isolate you're looking at and which population, anywhere from 45 to almost 77%. I think that part of that is the fact that we usually see vaccine effectiveness being higher for H1N1 strains. The antigen or epitope for H3N2 has always just traditionally been a harder match for vaccine. And so vaccine tends to do better when we see more H1N1, and it tends to do less well when we see more H3N2. So the fact that it's kind of a 2/3, 1/3 majority isolate of H1N1 sort of bodes well as we go into the upcoming season. I will also highlight that we typically see vaccine effectiveness being higher in young children, and there aren't quite enough numbers in this group to represent that, and so there's no official recommendations, but typically that is the case. The thing to just keep in mind, and I know that all of you in practice appreciate this, over the last couple of years, we are seeing declines in the rates of children getting their flu vaccine. And right before the pandemic, we were sort of at historic all-time highs. And since then, we've sort of been on a slow, steady decline. And I want to stress, this is not all just hesitant parents, okay? We have changed our access to flu vaccines. I think many of you can appreciate that what we once used to do with sort of clinic all-day vaccine days, I think it's rare that practices are doing that now, that we've offloaded a lot of flu responsibilities to pharmacy, which has then increased some of the logistics families have to do, obviously layered on top of misinformation and hesitancy that's been rampant after the onset of the pandemic. And so now we're sort of have backslid by almost 10 years in the rates of vaccination in the kids, the youngest kids 6 months to 4 years, the school age kids 5 to 12, and then our teens and preteens 13 to 17. And so we still have a lot of work to do. So I'm going to say we're probably going to have a pretty active flu season this year. It's unclear what the distribution will be, but I suspect it'll be very similar with a majority H1N1 and a little bit of H3N2. And I think, unfortunately, we're going to see that there may still not be as many people who are seeking vaccine as we would like for a lot of the access issues we've talked about. And so I think I would still stress the idea. I'm going to stop sharing for a sec. Stress the importance of flu vaccination for your patients. Again, there's a version of flu vaccine for any patient 6 months and older. And be very broad in your interpretation of who might be at higher risk of flu complications. I think the talking points are also to stress that in any given year, between 100 and 200 children die of the flu or of complications of the flu, the vast majority of whom are healthy and don't have any pre-existing condition. And many of those kids were unvaccinated. And that the data out there does show a really strong protective effect against severe complications and death for vaccine. And so I think speaking to families about the benefit that even if they do get the flu, that the vaccine will work in their favor to keep it more on the mild side. And the CDC several years ago had a really successful campaign that they used where the tagline was "from wild to mild." And it was just to stress the idea that the vaccine, while it may not prevent every case, really has benefit when it comes to preventing the worst outcomes. Okay. All right. So that's my flu segment. And now we're going to shift over to a little bit of COVID. So I'm going to share this screen now. Okay, so what I hope you're seeing is the page now from the AAP that links to the official recommendations for COVID-19 vaccines. Yeah, I see Chad's head nodding, so that's my confirmation. I appreciate that. So I know many of you have sort of seen the high-level details, and my point here is not necessarily to walk you through every little bit here, okay? But I want to just hit the highlights, okay? Which is stressing the idea that the youngest kids, most of whom are not vaccinated, are part of an active recommendation for vaccine. And that is actually replicated in other settings, okay? So thinking about that being the highest risk for severe disease, and then children, older children with other risk factors, and the table here sort of gets at broadly interpreted all of the potential risk factors that are out there. And again, I would encourage all of you to err on the side of inclusion here for children who may have official recommendations, okay? That being said, I would say that even kids who otherwise are healthy can be included in this if their parent wants them to get vaccinated, okay? And it doesn't necessarily have to need a prescription or have shared decision making. I think obviously you're going to want to discuss the potential benefits of this vaccine as you do. I do a lot of work with long COVID and long COVID in children. And without going into a whole separate lecture about long COVID, I will just stress that vaccine has a protective effect against the acute infections, as well as the potential development of long COVID. And that's been showed in many studies. It's not 100%, but it is the best we have out there. And for many of you who have had kids who have long COVID in your practice, you recognize what an impact it has for that child in their either school life or extracurricular life, and then the downstream impact that has on the family and the parents in terms of their expectations for their child and what happens. And so, again, these are all potentially preventable with COVID vaccination. And so I would stress that there's direct significant benefit for kids that have health conditions, both for against severe disease and mortality. And that's even with the current Omicron and Omicron derivative variants that are circulating now. But also even for otherwise healthy kids, I will say that we see a lot of kids in the hospital still, sort of every day of the year, who aren't necessarily hospitalized because of their COVID, but they are hospitalized because after getting COVID, they got secondary bacterial infections, really severe sinusitis with CNS extension, really complicated pneumonia requiring a chest tube or surgical drainage, or a bad bacteremic illness that all seemingly started with the initial COVID event, okay? And so as you're talking with families about the potential benefits, I think those things are worth mentioning. Those are things I always mention. I'm like, well, it's not just the COVID that's going to get you. It's that COVID opens the door for all of these other things. And I think that's where we really see the burden in our patients now. Okay. All right. So that's my COVID segment. So now I want to just highlight, there have been a lot of questions about how can all of you, what tips can I give all of you to try to discuss those parents that are having vaccine hesitancy. And so I'm going to point out, I was just at the Infectious Disease National Meeting this past week, and so I went to a session actually that covered this really nicely. And I was reminded about this resource that I want to highlight for you. So hopefully you're seeing my screen now. It's an AP Pediatrics publication that says strategies for improving vaccine communication and uptake. And so I saw Chad give me the thumbs up, so it means you can see it, which is great. So I want to just highlight, I'm not going to read and review this whole thing. I want to highlight a couple of key points that I think are really the best advice that I can give all of you, okay? Which is one, I think we sometimes unintentionally create or actually, before I start that, one point that I always like to go back to, it's affirming for me, and I hope it can be affirming for all of you. And one of the lead speakers at this session really highlighted this point, is that if you actually look at studies of the rates of vaccine hesitancy among parents over the last 10 years, they're actually relatively constant, okay? And what I mention in every TV or newsprint interview that I do is that if you look at the rates of vaccination, that 90% of parents vote with their feet every single year to get vaccine for their kids, okay? They didn't ask for these changes. They were perfectly happy with the vaccine schedule as it was, or as it is, okay? And so we spend a lot of time and effort talking about parents with hesitancy when we really should be focusing on the fact that the vast majority get their vaccines on time according to the schedule, okay? And so by talking about it all the time, we actually serve to legitimize the concerns that are raised. And so I would really, again, we have to think about how we talk and how we discuss the issue. And I think we need to go out of our way to emphasize the majority opinion that's out there. The vaccines are safe, they're effective, and parents take their kids to get vaccinated. Okay, so that's my main take-home point. I want us to stress the positive here. So now let's talk about the parents with hesitancy and trying to see which of those we can work with to get their kids vaccinated. So this paper highlights a couple of communication strategies that have been shown to be effective. Some of you may be familiar with some of them, but I just want to make sure we cover them at a high level. One is the idea that when we talk about vaccines, we use what is called the presumptive approach. So one can appreciate that sometimes we may inadvertently create confusion or uncertainty. If we say, little Johnny's here, he's 4 years old, we usually give, the MMR vaccine, the varicella vaccine, and then some of the kindergarten boosters. Is that okay with you? Right, and that's a fairly innocuous statement, but by saying, is that okay, you're actually creating uncertainty that may or may not have been there. Versus what is the presumptive approach, where you say, little Johnny's 4 years old, according to the vaccine schedule, we're gonna give the MMR vaccine, the varicella vaccine, and you may or may not have that mixed in with other boosters. And so we're gonna put that on the list and do that at the end of the visit. Okay, again, you're stating that it's a matter of fact, it's our standard of care, it's part of the recommendations. And in studies that have been done comparing those two communication strategies, even though the content of what I said was almost exactly the same, when you use the sort of questioning approach, 40 or 50% of parents get vaccine without question, and there was more sort of opportunity for them to raise issue. versus 80% or above when you use the presumptive strategy. Okay, so subtle changes in language, I think, can avoid some of the challenges that we have. The next point I would want to make is for those parents that have some degree of hesitancy and do want to raise a specific concern about a vaccine. This, I want to move this. There we go. Sorry about that. Okay, can you see this table now? So this basically, this is figure 1 from this paper. Again, I'm not going to walk through it, but this this paper talks about some of the motivational interviewing type techniques that can be used when parents raise concerns about this. So this is actually the presumptive approach. So this is basically what I was just talking about. And it gives you some strategies for following up if a parent still has some concerns about side effects or safety, or I read on, on Instagram or saw a TikTok video about somebody saying that, they grew a third limb after getting vaccine, right? So all that stuff you can talk about them, okay? The second piece is the motivational interviewing piece. And so this is basically talks about some of the techniques that you can use to validate that a parent is concerned, progress to sort of do some myth busting around what concern they raised about safety or about effectiveness or about some other aspect, and then ask permission to share. So again, you're showing respect. I think that one of the points that was raised in the session is that we often just try to do a data download on the parents and say, we're going to pummel them with all the facts about vaccines and the like. And what the research actually shows is that that ends up galvanizing a parent's concern and sets up more of an adversarial relationship rather than sort of a partnership or collegial relationship. And so these techniques to communicate for motivational interviewing are designed to avoid any sort of adversarial arrangement and validate the concerns while at the same time pivoting to what is the basis for why we give vaccine and the discussion about the enhancement. But obviously you still end with, if you look at this autonomy support, you're putting it in the parents' hands after you've done your best to share the information and turn a lot of those concerns around or dispel some degree of misinformation if they've read that vaccines aren't studied and they aren't safe, okay? So just to give you an example. So I put these in the chat, the links to the 2 papers in the chat. So when Chad and team send out their debriefing with info, you'll have links to those. And I'll also give him the flu slides that I shared. So now we're back. And I think we've got about 15 minutes for questions, Chad. So hopefully that'll take us to the home stretch.
Yeah, thank you. I can't thank you enough for taking the time to do this. As I prepared you a little bit for some of these questions, I encourage everybody here, if you have questions live, to send us I'd like you to do that. But I think you covered a lot of what I originally sent you. Is there anything you could share about RSV vaccines? I know it's limited based on age. So can you kind of just reinforce that?
Sure. So it's important for us to just remember a couple of things, right? So the RSV vaccine product, the RSV products that are out there are actually not active vaccinations, right? It's a monoclonal antibody that is given to healthy infants in their first year of life, first season of RSV, and then to some children with high-risk conditions in their second year of life, okay? The data that's out there is that these are exceptionally effective at preventing severe RSV complications and hospitalization, okay? And so the more we can implement them, the better. We now have 2 products to choose from. Before we had the nirsevimab product, and then just recently the clesrovimab product was just approved. I don't know how much it's gotten into anyone's office just yet. It's still fairly new, so my guess is many of you probably don't have it. But at some point there'll be some competition. The idea is that at some point in the future, most of these kids will get the RSV monoclonal in the nursery soon after birth, the way we do all of our post-delivery care with hepatitis B and other things. That has still been not the majority of the cases for many practical reasons. And so obviously many of you are also giving it at one of your early visits after discharge. And it's fine, it still works well. It should certainly last through the first season and maybe even into the early part of the next season. We also know that there are RSV vaccines for pregnant women designed to not only protect them, but to give the infants passive antibody at birth for the first several months of life. Currently, the guidance is that you should either do one or the other and not both, because it's not clear that both are needed. What I would add, and this is data that hasn't been published, it was just presented at the meeting I was just at, and someone was telling me about it, so I didn't actually see this, but there is some emerging data that perhaps both is better. And so there may be a point where we are recommending RSV vaccine for the pregnant women, and then follow up with RSV monoclonal for the baby after delivery or at delivery. Okay, so stay tuned for that. That's not published, so that's still something that may be coming soon. And then the last thing I would just remind is that, for all those grandparent caretakers that are out there, we do have several different versions of RSV vaccine for the senior set. And we know that grandparents can infect grandkids and grandkids can infect grandparents. And so RSV vaccination for the seniors is really, really critical because not only does it keep the kids from getting sick, but it also keeps adults from getting very sick and or dying. RSV is a major burden on older adults too. And so there's many products out there. The more you make people aware of them, I think the better off we'll be.
And what is that age for the age range?
So I think
for
right now
seniors?
it's majority 65 and older. There are some patients with high risk conditions, I think, where it goes lower than that, but most of the study's been done at 65 plus.
Okay, thank you. And for those of you watching, I will, as you know, I'll be sending the recording out. But with the recording, I will be sending a link about Dr. Tina Tan's RSV talk, and she addresses a lot of this in that talk. And for those of you who are eligible, it's actually a CME talk that you can use a recording too. So it's a win-win for all of you here. So on that,
Yeah.
listen. So I think the last question that I think may be relevant here is that I'm looking here because again, you answered so many of these. There is a question about, all right, so babies, yes, we gotta get these toddlers, yes, but how about the teenagers, young adults who are on TikTok, on social media?
Yeah.
They go to the parents like, this kid got the third appendage because he got that. Listen, we know it's silly, right? But it's got to be addressed, right? Because this is the world we live in.
Yeah, I do think that we need to really be talking to those kids directly about how they process and consume information, and when it's appropriate if they want to do a dance and watch people dancing on TikTok, that's great. But I think we also need to directly communicate with them about what is reliable health information and what is appropriate for TikTok versus other stuff. So one, I think we need to respect them and talk to them directly about, and there are lots of reliable people who have credible medical training and background who engage with people on TikTok, and we can work with our kids to try to consume that content as a balance and diversify their feed so they're not stuck in the same sort of circles where misinformation and disinformation and these tales are being spun. So I think that's one thing. I also think we need to really increase our discussion about the options, and there are lots of other options. So one of the, I see in the Q&A, I'm sorry, I'll try to answer some of them, but there was one question, let's say, about the intranasal flu mist versus the injectable vaccine. And so, for instance, so what I would say, the top line I would say on that is that the data from the last several years, mostly from California, but also internationally, shows that the intranasal flu mist has sort of equal effectiveness in preventing flu as any injectable. So you might, like, there may be a parent who says something about, well, when I got the injectable, I had this or I had that. Or if a kid just is squeamish and says, well, I had a sore arm for a week and I'm the star pitcher on my baseball team and I'm not going to get the flu vaccine. And you'll say, well, actually, there is a different option. And if you don't have that in your office, you may be aware that certain pharmacies are able to treat it. And actually, some of you may have heard that there's actually a home delivery program now. And so parents can actually order it for themselves and for the kids through the website. And so that may be, I think the point that I'm trying to make is that we can be creative about offering different patients different options because we never really know which one best suits them. Only they do. And it may be that certain options will just appeal to them in a way that gets around their concerns or addresses some of their lifestyle issues. If they just can't, they've got 5 kids all with their individual extracurriculars and there's no way they're going to get them all in for their flu shots and they're not coming in 5 separate times. And so maybe some of these other options is going to be better for them.
How about the talk with the new CDC and ACIP is going to recommend
about splitting up vaccines? Yeah. So, so one, I just want to say I'm not going to get on a political soapbox here, but what I would say, how I would talk about this, is that the original vaccines were all combined. They were studied in thousands upon thousands of young children. And then obviously we've administered the combined vaccine to millions upon millions upon millions of children worldwide. We know that they work well together and that if we were to split them up, that means that individually parents would be coming for any number of more visits. The infants would receive any number of additional injections. And so I keep going back to the point that I made at the outset, which is that the vast majority of parents vote with their feet for the current vaccines given at the current schedule. They are not asking for these changes. And I would say that when you look at the AAP, which has been doing vaccine recommendations for 100 years, long before the ACIP existed, they have vaccine recommendations that are effectively unchanged. And so there are a lot of these points, whether manufacturers are actually going to make some separate vaccine, I'm not sure. I think that they also are shrugging their shoulders because of all the uncertainty of recommendations. And they are largely standing pat, saying, we have recommendations that are out there from the AAP and other organizations, medical societies, that aren't changing anything. And so they're not changing their products right now. And so I have a feeling that this is going to be a lot of talk, but that this is not something that actually is going to happen. But that's just my personal opinion. I don't know anything and I don't know anybody. I'm just a guy. But just the conversations I've had suggest to me that there's a lot of political bluster happening. And I'm talking to you guys as the people on the front line.
Yep, our peers. So a couple more, if you don't mind. So
Sure.
If Beyfortus was given during the spring and a healthy infant is still 8 months going into fall, is it ever recommended to get a second dose?
Yeah, so this is the sort of gray area. At this point, I would say that the official guidance is probably going to be no. That being said, I'm not aware how much, let's say, insurance companies are policing this. And perhaps all of you can tell me if you've had patients that have been in this boat where the parents ultimately get billed for the additional dose. But I think this is one of those where the guidance is not likely to change if you were to give a second dose on your own based on this and work with the parents if the insurance company refused to try to petition for that. I think I respect that decision. I don't think there's anyone to say that could be wrong. But I would say that as we learn more about this monoclonal, it does have quite a long half-life, probably longer than just the one season. I just can't tell you how long it's going to be. It's probably not going to be the whole second season, but it probably does have some activity into the second year.
Okay. So how about thoughts on flu mist nasal versus flu shot for pediatric patients?
Yeah, so I think I sort of tried to cover that one before, which is that.
Sorry if I missed that. Yeah.
No, that's okay. The vaccine effectiveness data that's out there suggests that currently it seems to be an equal option. And so if you have kids that don't like needles, or you need 5 of your staff members to hold a kid down, but you know that they'll do the intranasal spray just fine, I think it's a perfectly fine option. As I mentioned, they have a home delivery option. So if you have parents that say, well, I'm not going to be able to make it, you can at least mention that they could order a vaccine for any child that doesn't have a contraindication. And so those kids are kids that have immunocompromising condition. I would say more significant asthma. If a kid just had mild asthma that's well controlled or just wheezing episodes post-viral, I personally have given people the intranasal in that setting. And I will just share that I've done some research with the vaccine in the past, and we had almost 10% of parents say if they didn't have the intranasal vaccine, they would have just skipped vaccine altogether. So I think there is a minority of people that for them, it's the intranasal vaccine or nothing. And so for a while they had no option. But now with the return of intranasal, I think it's an important part of our portfolio of flu vaccine.
Thanks. And then for some of you typing in the chat room anonymously, appreciate you coming on, but some of you are asking about what we would recommend about reusers and dismissing them from your private practice. We can't comment on that, folks. I'm sorry. We can't comment on what you should do in your private practice.
Yeah.
That's something you have to discuss amongst your peers.
Yeah.
So
I will.
But thank you for.
Yeah. Chad, if we have 1 minute, I can probably try to answer the first 2 questions in the Q&A. The first is yes, we are starting to see sort of the initial blips of flu activity. It's definitely out there. And so start to look for it more, start to suspect it for it more. And I think we're in the midst of prioritizing our testing for the rapid COVID flu RSV testing. If it hasn't already hit prime time. And then the second is how important is that flu booster in the first season? That's the ideal world. The reality is that's the recommendation. The real world is that, like maybe 20% or less actually get that second dose. So yes, it's important for establishing immunity. And you should certainly try as best you can to get that second dose in. But still that first dose has an impact, just not as much as we would like.
All righty. That is a lot to cover, my friend. And I really, really appreciate it. We all do for you joining us today. So if I receive any other questions, I'll send them your way and we will post them in the comments section if we're able to. So Dr. Jhaveri, thank you. We look forward to seeing you soon.
Good luck, everyone. Yeah.
Take care.
All right. Take care. Bye-bye.
So I'd like to thank everybody for joining us today. If you have any other questions that's not regarded to our presenters, but more for Julie and myself that you have, whether it's referring your patients or anything else, we encourage you to do so and hang on and do that or type them up. Otherwise, Dr. Taji, can you please just type in your question there? We have too many people online to be able to take live calls. That said, earlier today, I mentioned bookmarking the URL for our referral toolkit. So please do so. We can help you do that. If you're watching the recording, like I mentioned, Dr. Tina Tan had a great talk on RSV. Look for that here in the comments section. I will post that on our YouTube page, that link, and we will look forward to sending that all out to you soon, the recording and everything else. There is a few more questions coming in, so I'm going to go ahead and try to address those. Regarding referral phone numbers at the new facility. So there is no referral phone number for the Schaumburg facility. Thank you for asking that. Like everything else, we encourage you to use KidsDoc, use MyChart, Epicare Link. You can do direct messaging. There are many of ways that you can refer patients, but there is no direct phone calls that we take into the outpatient centers for referrals. So thank you. Again, thank you everybody for joining us today. And again, thank you for being such great partners with Lurie Children's. Julie and I appreciate all that you do for the kids in our community. And please call us, email us if you need to speak with us directly on anything. But with that, thank you and have a great day.